కేర్ వైజాగ్.
తర్వాత నెక్స్ట్
కేర్ నాంపల్లి. నెక్స్ట్ పంపిస్తాను లిస్ట్.
ఒకసారి పంపించండి. కేర్ తర్వాత
మీదే అనుకుంటా.
అమ్మాయిలు రెడీ చేయాలి కదా.
ఎవరిని?
అదే టాక్ రెడీ చేయాలి కదా మా వాళ్ళని, మా స్టూడెంట్స్ ని
రెడీ చేయాలి. చెప్పేయండి ముందే.
చెప్తున్నాను. ఎప్పుడు అక్షిత చేస్తాడు? అక్షిత
అనుకున్నాను సేమ్ డైలాగ్. నేను ఇప్పుడే సేమ్ డైలాగ్ ఇప్పుడే అడిగాను నేను. ఇప్పుడు ఏమవుతుందంటే అన్నా గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ అన్నా.
ఎక్కడున్నావు అన్నా? ఏదో బ్యాగ్ తగిలించినట్టున్నావు, బెల్ట్ లాగుంది.
బయలుదేరుతున్నా, కార్ దగ్గరికి బయలుదేరుతున్నాను అన్నా.
నీ క్లాస్ ఎప్పుడు కార్లో అయిపోయింది అన్నా?
నాది కార్ లోనే అవుతుంటది క్లాస్. ఒక 8:15 అట్లా బయలుదేరుతా. సో 15 minutes చూసేసి ఇంకా బయలుదేరడం అవుతుంది. కరెక్ట్ గా ఐసీయూకి వెళ్ళేసరికి అయిపోతుంది 9కి.
దారిలో ఎవడన్నా అడ్డొస్తే మీరు తిడితే మమ్మల్ని తిడుతున్నా అనుకుంటాం. మరి దారిలో ఎవడో వచ్చేసి సన్ బ్రేక్ వేసి కళ్ళు చూసుకుని వెళ్ళరా ఏంట్రా నేను తిట్టాను కాడిని దారిలో.
ఎక్కడన్నా అన్ని మ్యూట్ లో ఉంటాయి కదా.
ఇంట్లో ఉంటాయన్నా నువ్వు మాట్లాడే టైంలో. అప్పుడు మమ్మల్ని తిడుతున్నాయేమో.
అన్న నాకున్నది చిన్న కారు, నా కారు ఎంత తొక్కినా గానీ పోదు.
గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్. గుడ్ మార్నింగ్. యా అక్షిత్.
సార్
వినిపిస్తుంది.
సిస్టమ్ ఆన్ అవ్వలేదు.
ఏం చేసావు?
ట్యాబ్ నుంచే ప్రెజెంట్ చేసేస్తా.
ట్యాబా?
పని చేయండి. ట్యాబ్స్ ట్రబుల్ ఇస్తున్నాయి కాబట్టి డేవిడ్ సార్కి పంపించేస్తే అవసరం అనుకుంటే తిప్పుతాడు అట్లీస్ట్.
అక్షిత్ నా దగ్గర ఉందా? అక్షిత్ నువ్వు నన్ను ఓపెన్ చేయమంటే చేస్తాను. నువ్వు ఒకసారి ఓపెన్ చేసి చూడు.
సార్ ఇప్పుడు కనిపిస్తుందా చూడండి, ఒకసారి చూడండి. అవ్వకపోతే అప్పుడు మీరు ప్రెజెంట్ చేస్తుంది.
అంటే ప్రెజెంటేషనా?
నేను ఒకసారి ప్రెజెంట్ చేస్తున్నాను, స్క్రీన్ షేర్ చేస్తున్నాను. సార్ ఓన్లీ ద హోస్ట్ కెన్ షేర్ ఇన్ దిస్ మీటింగ్ అని వస్తుంది సార్.
ఓకే, ఐ వాంట్ యూ టు మేక్ ద ఐ విల్ మేక్ యూ ద హోస్ట్. ఓకే, 1 second. బషీర్ 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 ఓకే, ఒకసారి లైన్ లో ఉంది. ఒకవేళ నీ దానికి ఏమైనా ట్రబుల్ వస్తే వెంటనే నేను ఓపెన్ చేస్తాను.
సరే.
మన సిస్టమ్ ఏమైంది?
అది ఇందాక నుంచి బఫర్ అవుతూనే ఉంది సార్.
బఫర్ అవుతుంది, అది ఓపెన్ అవ్వట్లేదు అసలు సిస్టమే. ఇదేంటి సురేష్ లేడు అక్కడ?
సిస్టమ్ ఓపెన్ అయింది సార్, అది పవర్ పాయింట్ లోడ్ అవడానికి 15 minutes పట్టింది ఇప్పటికి.
దాంట్లోనా? బషీర్ బషీర్ డాక్టర్ అక్షిత్ ని హోస్ట్
take it.
గుడ్ మార్నింగ్ సార్.
సార్ గుడ్ మార్నింగ్. అక్షిత్ ఇప్పుడు ఓపెన్ చేయి. గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్ సార్. ఇది మామూలుగా స్టార్ట్ అయిపోయిందేమో అనుకున్నా.
అవుతుంది సార్. అక్షిత్ ఓపెన్ చేసావా?
సార్ చేస్తున్నా సార్. సార్ వచ్చిందా సార్ ఇప్పుడు
రాలేదు,
సిస్టమ్
నీ ఫోటో
ఒక్క
వచ్చింది.
నిమిషం జాయిన్ అవుతున్నా.
సిస్టమ్ లో ఓపెన్ చేస్తున్నావు కదా?
ఓపెన్ అయిందా సార్?
లేదు, నీ దగ్గర ఓపెన్ అయిందా?
నేను ఇప్పుడు చేశాను చూడండి, ఇప్పుడు అవుతుంది.
ఆ?
ఇప్పుడు ఓపెన్ అవుతుంది సార్.
ఓపెన్ అయిందా?
సిస్టమ్ ఓపెన్ అయింది.
అయితే సిస్టమ్ లో ఓపెన్ చేయ మరి. లింక్ ఓపెన్ చేసావా?
సార్ చేశాను సార్.
లింక్ ఓపెన్ అయిందా?
అయింది.
మరి పీపీటీ ఓపెన్ చేయ దాంట్లో.
Host has disabled participant screening screen sharing అని వస్తుంది సార్.
పని చేయి, ఇదిగో అక్షిత్,
సార్
నువ్వు ఏదో ఒకటి స్టాప్ చేయి, ఆ సిస్టమ్ స్టాప్ చేసి, లేకపోతే నేను ప్రజెంట్ చేస్తాను.
ఇప్పుడు ట్రై చేయండి.
ఇప్పుడు ట్రై చేయి.
వచ్చింది సార్.
అయితే ఇప్పుడు ట్యాబ్ స్టాప్ చేయి.
ఆపేసాను సార్.
ఓకే, ఎక్కువ వస్తుంది.
ఇప్పుడు వస్తుందా సార్?
వస్తుంది. ఇప్పుడు ఇది చేయి, పీపీటీలో పెట్టు.
పెట్టాను సార్.
Yeah, shall we start? Yeah, good morning all of you. Sorry for the late. Today Dr. Akshit is going to talk on altered sensorium in ICU, which is the most commonest presentation. The casualty, the people are, particularly old people, are presented with altered mental status, confusion, due to several reasons. So many reasons are there to diagnose these cases. So it is very important for all the intensivists to see the cases and how to approach these patients with presenting with altered mental status. Today, Dr. Akshit is going to elaborate on this, how to identify these patients and diagnose and appropriate treatment for that. Dr. Akshit, please go ahead.
Good morning, one and all. I'm Dr. Akshat, here to discuss today about how to approach a patient of altered sensorium in an ICU. Am I audible to all?
Yes, go ahead.
Coming to altered sensorium, it is the most common presentation we see in ICUs. What exactly sensorium is? Sensorium, it is the ability of the brain to receive and interpret stimuli. How can you tell whether the patient is in sensorium or not? It depends upon evaluating the level of consciousness. Altered sensorium itself a symptom of an underlying disease. Altered sensorium occurs due to impairment of cognition or arousal or behavioral disturbances. If a patient is in altered mentation, which is of acute onset with fluctuating course and indentation with either disoriented thinking or altered conscious levels, it can be termed as delirium, which requires further evaluation and investigations has to be done. Coming to the most common conditions which are related with altered mental station is delirium and dementia, which we often see. Delirium, it is an acute onset alteration in mental status with fluctuating course and impaired attention. Coming to dementia, it is a chronic progressive deterioration in the level of cognition. Mostly we even come with seeing patients with amnesia, which is different from delirium, as the patient will have loss of past memories despite being alert and normal attentiveness. Coming to psychosis, it is a mental status involving loss of contact. This term delirium can be used as in many of the synonym ways. It is termed as acute confusional state, acute brain failure. The patient may have symptoms from unconscious state to agitation and combustion. He can be confused. He can present with encephalopathy. If the patient is in long-standing stay in ICU, he can present with ICU psychosis. There. Coming to the major difference, how this delirium and dementia can be described. The delirium and dementia both are of the same condition, but if it is acute condition, it can be termed as delirium. If it is a chronic one, it can be termed as dementia. Coming to delirium, it is an acute impaired attention because of disorganized thinking or lack of awareness. It is often reversible. It has a very fluctuating course. The patient usually be in clouding state and has impaired attention. The patient will have cognitive deficits. Delirium should be elevated immediately and should be treated. Most common cause of delirium are underlying metabolic disorders or drug toxicity or underlying ischemic systemic disease. Coming to dementia, it is chronic progressive disorientation. It is long-standing and is often irreversible. The patient will present with memory problems. He will have global cognitive deficits. It need not be evaluated immediately, but should be evaluated and be treated. Most common causes of dementia are Alzheimer's disease, atherosclerosis, or because of multiple small strokes. Coming to the level of consciousness, he can present as combating state, or he can be hyper vigilant, or he can be as normal, awake, confused, delirious, somnolent, uptended. He can be drowsy, he can be stuporous or comatose. I'll just level a few. Combat is the state in which the patient is very aggressive and is very difficult to control him. We need to first physically restrain and need to even pharmacologically sedate him to control that sort of patients. Hypervigilant is something less than this combating state, but the patient is bit aggressive, but can be controlled. Alert is a normal, awake and responsive state. Coming to drowsiness, it is a state of apparent sleep with brief arousal when oral commands are given. Somnolence is an state in which the patient is easily arousable to voice or touch and follows commands. Uptended is arousable with only repeated painful stimulus. Coming to comatose, no arousal despite vigorous stimulation or no purposeful movements. Mostly in comatose, brainstem reflexes even can be absent. What are the risk factors in which the patient usually presents in his altered mental status? There are multiple conditions, but most commonly seen is the patient who is having a known case of dementia. Because of older age patients can present as in state of delirium to ICUs. The one who are in multiple comorbidities, using multiple medications, because alcoholics and all who are chronically malnourished and who are on substance abuse. This is an Richmond agitation sedation score, which is usually used to level assess the level of alertness and agitated behavior in critically ill patients. It ranges from the state of unarousable, which is deemed as -5 to +5. This is +4. This is clearly stating in which is commonly used in ICUs, modified Richmond agitation sedation score, in which the patient who is having a score of +4 is very combative and is a danger to the staff. And the patient who was normal, he has usually alert and calm, and to the other extreme, who is unarousable, doesn't respond to any voice or painful stimulus. Coming to the pathophysiology, what causes this delirium? There are multiple things which can trigger this. Most common conditions are any of the bihemispheric dysfunctions like cerebral diseases like stroke and all, or metabolic derangements or toxic derangements, which can cause a disruption of the synaptic communication and neurotransmitter imbalance, causing to delirium. Or there are other causes because of brainstem dysfunction or activation of RAS system, or any neuronal atrophy or dysfunction causing increased glutamate, or any of the congenital conditions which finally cause this delirium. Here are a few examples of how the alteration occurs in the neurotransmitters, because of which the patient presents with delirium. Coming to the most common causes of altered mental status, it includes neurological conditions which can be termed as infectious, which can be meningitis, encephalitis, abscesses, empyema of brain, or any of the prion diseases, or any of the underlying systemic infection causing sepsis, shock, and organ dysfunctions can cause this neurological altered state. Few causes of inflammation also can lead to altered mental status. There are next, coming to the vascular cause, because of any vasculitis diseases, or because of any atherosclerotic changes and all causing transient ischemic attacks or ischemic of hemorrhagic strokes. Coming to tumors, any of the space occupying lesions or metastasis can cause altered mental state because of edema and all. Coming to metabolic causes, to list out, there are many causes, many factors which causes metabolic derangement leading to altered mental stages, which will be discussed in the coming slides. Next, we need to check if the patient is having any history of any neurological disorder, or is a known case of seizure disorder, using any medications for that, any recent hospitalization history, any of the patient drugs which the patient is using, because of which there can be dyselectrolytemia causing the encephalopathy. There can be even toxicity of endogenous products like the uremia causing or hyperammonemia, or because of hypercarbia or hypoxia, the patient can be presenting in altered mental status. Because of exogenous products, the patient can present, for example, the patient using sedative drugs, psychotropics, because of which he may present to us in altered mental status. Next, one of the most common things which we see in neuro ICU is the traumatic brain injuries, which can range from concussion to and diffuse axonal injury. Coming to endocrine abnormalities, the most commonly one which we encounter is the dysglycemia. The patient presenting with hypoglycemia and is unconscious, which is can be treated very, which must be detected very and should be treated accordingly. A few conditions like myxedema, coma, and Addison's crisis can also present to ICU in altered mental status. If the patient is a known case of psychiatric disorder and is using drugs, or a known case of schizophrenia or a bipolar disorder, can present to ICU with altered mental status. Any of the underlying autoimmune conditions like SLE also can rarely present to ICU in altered mental status. If the patient is having either hyperthermia or hypothermia, also can present with altered mental status. If there are any other system involvements like cardiovascular disease causing AF and all, he may present with stroke and all to ICU. Even we see in patients who is a chronic alcoholic and is in withdrawal can present to us with delirium, or the one who is using regular anti-epileptics, if he has stopped all of a sudden, can present to us with seizure and delirium. If a patient is with us in ICU for long-standing days, he can present with ICU psychosis and delirium. Even the post-op patients, usually few patients can present with post-op delirium. There are other causes, example of osmotic demyelination syndrome or demyelinating encephalopathy, which can present to altered mental status. This is what has been listed out in this slide. Coming to this, what are the common cases in which an elderly patient can present is the patient, if he has having any old medical insult, like recurrent strokes or known seizure disorder can present usually, or because of any history of trauma, or because of MI or any abnormal rhythm can present with stroke. The most commonly infections like UTI or any cellulitis, because of which you can go into sepsis and present, so on. The most common screening test for cognitive impairment in old patients used is a 6-item screener. Coming to the factors which can and cause is which has been listed now till now. Coming to rest now, I said about encephalopathy. So I just want to discuss what are all the conditions which can cause metabolic encephalopathy. Usually, a metabolic encephalopathy can be diagnosed if the patient is in a confusional state to coma with no focal neurological deficits, with normal brainstem reflexes, and no neck stiffness. Coming to the most common causes, the patient can be post-ictal. He can be termed as septic encephalopathic if the patient is in sepsis and shock because of any dysglycemia like hypo or hyperglycemia can present with encephalopathy. Because of dyselectrolytemia, most commonly hyponatremia and hypernatremia can present with encephalopathy. We usually see patients who are on chronic kidney disease, patients on frequent dialysis can present with uremic encephalopathy. The patients of acute hepatic failure or chronic hepatic failure with hyperammonemia can present with hepatic encephalopathy. The alcoholics usually present with Wernicke's encephalopathy. Usually, a few patients of hypertension or uncontrolled can present hypertensive encephalopathy. The condition patients who have present with respiratory failure, or if they are type 1, they can present with hypoxic damage causing hypoxic encephalopathy, or hypercapnia can lead to encephalopathy and respiratory arrest. Toxic patients, endocrine abnormalities, and all I'll discuss. Coming to this, if how to evaluate a patient who come to us with altered mental status. First, initially is the history taking, which should be taken in detail, followed by clinical examination and neurological status examination, which can be aided by laboratory investigations and imaging studies. In history, one should ask for when did the symptoms begin and what is the duration. Any history of trauma, any medications or substance abuse which the patient is using for any of the underlying conditions. Next, previous or family history of any psychiatric illness. In adults, we should see if the patient is in dementia too. Coming to examination, if the patient is unconscious and with Heli's history of trauma, we should secure C-spine. And for basic assessment, we should look firstly for the vitals and look at sugars. Send in ABG if the patient is unconscious, and should check for rhythm and pulse of the patient. If the patient is unconscious, or look for reversible causes like hypoglycemia and all, which are very fastly, rapidly reversible and are self-limited causes. Coming to primary survey, assess for his airway, breathing, circulation. Look for any signs of shock, assess GCS and the breathing pattern, and if required, we can secure ABC. Coming to neurological assessment, look for any focal neurological deficit, any evidence of infections like neck stiffness and all, or any of the systemic infections like cellulitis, which can cause to, or you all. Look for any, if the patient is a known case of seizure disorder or in post-ictal status, any evidence of trauma or suspicion of toxin ingestion or medication overdose or substance abuse. A patient with very low GCS, then look for brainstem reflexes. If there are any other systems which are significant, can be examined. Coming to this is a short flowchart of how the vitals can tell us about the abnormalities which is the patient is. If he is in hypothermia, it can be environmental or endocrine causes. If he is in hyperthermia, it can be infectious or environmental causes. If the patient is having tachycardia, it can be because of infections or endocrine causes. If he is in bradycardia, it can be because of dysarthmias. If the patient is having tachypnea, we can should look for toxic causing causes. If is in bradypnea, any opioid intoxication or signs of raised ICP should be looked for. If the patient is in hypertensive or hypotension, based on that, if he is in shock, look for what type of shock it is. If it is a patient is in hypertension, need to monitor his intracranial pressure and prevent him from going into hypertensive encephalopathy if he has not yet gone into, and look for saturations, look for any hypoxemia which can be treated with oxygen. Coming to the symptoms with which the patient comes. The patient may complain of weakness as in ischemic strokes, or the patient may have altered posture of limbs as in hemorrhagic one. He can complain of headache, he can complain of seizures, the patient may complain of nausea, vomiting, and he may complain of blurred vision, he may complain of fever or cold clammy skin. If he may present to us with disorientation to time and place, he can be restless, agitated, confused, depressed, or unconscious. If he is conscious enough, can tell of hallucinations. There can be seen tremors may be present. Few may complain of sleep disturbances or sleeplessness. If a patient is in under intoxication, any abnormal breaths, or if he is a known case of diabetic and is hyperglycemic, any fruity order breathing to rule out DKA can be seen. Whether it's breathing pattern, which I'll be discussing in few near. Any drug abuse like injection marks, drug patches, or coming to this symptoms in specific. If the patient is uremic, he may complain of anorexia, lethargy, coma. Usually we see few patients who are on dialysis in the initial stages of life may present with dialysis dysequilibrium, when the patient may complain of headache, nausea, muscle weakness, cramps, or fatigue. These are following features we see in patients of hepatic and comatose, ictus, abdominal distension, astraxis, caput medusae can be seen. The patients who are alcoholic may present in altered sensorium or may have ataxia, autonomic insufficiency, and memory impairment. Endocrine conditions and other vitamin deficiencies can also present with altered sensorium, like niacin deficiency and pyridoxine deficiency. I would like to discuss one more cause which usually present to ICU is non-convulsive status epilepticus. It is usually diagnosed when there is no other cause for altered mental status. The patient have prolonged post-ictal periods. It should be suspected in the patients who are awake but altered with disorientation, somatomotor symptoms, or automations, hallucinations, or new confusion or abnormal behavior. Coming to signs, if the patient has neck stiffness, we can deal in line of meningitis. If he is having a hemiparesis or hemiplegia, look for any cerebrovascular event. Based on the symptoms of spasticity, rigidity, myoclonus, we can deal with if the patient is an Alzheimer's or all. Coming to pupils examination, what are his breathing patterns, if there are any murmurs present, because of which to look for underlying endocarditis and all. If the patient has any history of syncope, if he is having ascites or astraxis, if oliguric, anuric, if in case of trauma, look for Rakunae or battle sign. Coming to the different breathing patterns, usually various breathing patterns which can be described as: one is Cheney strokes respiration, usually seen in patients with forebrain or that is bilateral cortical hemisphere or thalamic or metabolic disturbances, in which the patient has abnormal respiration in which periods of deep, shallow, and deep breathing alternatively is done. Usually, the patients with the midbrain or pons lesion presents with hyperventilation. If the patient has a lesion in lower pons, he may present with apneus. If the patient has high medulla or lower pons lesion, he may complain of cluster type. He may present with cluster type of breathing, in which uh, closely grouped series of respirations are present, followed by a period of apnea. If he is having lesion medulla, he may present with gasping or ataxic breathing. If he is having severe metabolic acidosis, as in DK, he may present with Kusimal's breathing, and which is usually termed as it has a fruity odor too. Next, coming to Caucus Cushing reflex. It is a condition usually seen with circulation, in which because of rise in blood pressure, the patient may have bradycardia due to rise in ICP, compression of the floor of IV of the ventricle, followed by a fall in blood pressure and tachycardia, causing medullary failure. Coming to the tools for assessment of mental status, we are described with signs and symptoms. Now coming to neurological, we have few scales for assessment of the mental status. The most commonly used one is GCS, usually used in trauma and in ICUs. There is other scoring systems like Cincinnati scoring stroke scale, NIS, National Institute of Stroke Scale, CAM, confusion assessment method. But coming to GCS, this slide in which you can see how to interpret a GCS based on this eye-opening verbal response and motor response, and how it changes from adult to pediatric age groups too. So, and lastly, we should even check for pupils, because examining pupils can tell us few conditions. If the patient has small and reactive pupils, we can consider a metabolic derangement. If the patient has pinpoint reactive pupils, there can be pontine lesion. If the patient has pinpoint pupils which are non-reactive, opioid poisoning can be suspected. If the patient has pupils in mid position and fixed midbrain lesion can be suspected. If the patient has irregular pear-shaped pupils, midbrain nuclear lesion can be suspected. If the patient has large and fixed pupils, brainstem lesion, hypoxia has to be suspected, along with drug overdose. Here are a few ocular examination findings and differential diagnosis. Coming to AVPU score, it is a score commonly used in ER to triage the patient and look for his alertness, if how he responds to verbal commands, how do he responds to pain, or is it unresponsive. Cincinnati stroke scale is the one in which the patient may we look for the patients for facial droop, arm drift, and speech, based on which we can assess if he is based on these two scores we can assess the stroke. Coming to this, this is a National Institute of Stroke Scale, which provides a quantitative measure of stroke-related neurological deficits. It has 11 different elements to evaluate the abilities. The highest possible score is 42, and the least one is 0. In coming to its interpretation, if a patient has a score of 0, there are no stroke symptoms. If he is having a score of 1 to 4, minor stroke symptoms. If he is having between 5 to 15, it is moderate. If it is between 16 to 20, it is moderate to severe. And if it is above 21, it is severe stroke. This is a slide describing about the confusion assessment methods in ICU. If a patient has acute change or fulminant course, look for is there any change in mental status from baseline, or the patient has mental status fluctuated during the post 20 per hour. If there are no signs, CAM ICU2 score is negative and the patient has no delirium. If there are any signs which stated above, then look for attention of the patient. Ask him to read a sequence of letters, or if he is unable to read letters and show pictures, if there are any small errors, it can be termed as no delirium. If the errors are greater than 2, then look for level of consciousness using Richmond agitation score. If it is other than 0, ICU delirium is present. If the RAS score is 0, but the patient is in disorganized thinking, with the errors of 0 or 1, then he can be termed as no delirium. If he's having more thoughts of disorganized thinking, or the patients with Richmond agitation score greater than 1 can be termed as delirium. Coming to various postures with the patient presence and how to interpret them. If he is having a presence with decorticating posture, it usually defines the cerebral hemisphere damages. If he is having decerebrating posture, it is because of damage to upper brainstem. If he is having pontine, if he is having abnormal extension of arms with weak flexion of legs, it is pontine lesion. If he is having flaccidity, it is because of medullary lesions. Then, if he is having a diagonal posture, it is mostly because of diencephalon lesions. Coming to investigation, routine blood investigations with coagulation picture, electrolytes to rule out electrolyte abnormalities, uremic, renal and liver function test rule out uremic and hepatic encephalopathy, ECG to rule out any of the conditions like MI and or AF and all. Thyroid function test to rule out thyroid abnormalities, and diabetic screening for hypo or hyper to look at the diabetic control, serum ammonia to rule out hepatic failure, serum cortisol levels to rule out Edison's crisis. The patient is febrile, send cultures. If is in intoxication, blood and urine toxic analysis. If required, a patient CSF analysis can be sent. If hemodynamically unstable, can repeat ECG, can get cardiac enzymes run and echo. Coming to imaging investigations, get chest X-rays or CT, HRCT done to rule out any lung abnormalities or any aspiration and all. CT is the most commonly available measure which can be done at any of the centers. Even if you have a luxury of MRI, can get an MRI done. In evaluation, you can get ultrasound, abdomen, and carotid Doppler. If the patient is in status epilepticus or there are no other causes and we are suspecting non-status, we can get an EEG done. If the patient is obese and obesity hypoventilation syndrome, then can get sleep studies done. The conditions which mimic this altered mental status include, I'll just list out them: psychogenic coma, dementia, brain death, locked-in syndrome, persistent vegetative state, akinetic mutism, frontal lobe disorders, which causes emotional disturbances, non-convulsion status epilepticus, and any of the psychiatric disorders like catatonia and all. Coming to the approach, if a patient is in altered sensorium or coma and is localizing, think of supratentorial causes like trauma, which includes EDH, SDH, intraparenchymal hemorrhages, any abscess or tumors, and infarct. If is localizing and infratentorial, as stated above before, look for cerebellar infarct, basilar artery thrombosis, pontine or cerebral hematoma. If there are no localizing signs and if he's having stiff neck, can think of meningitis or SAH. If there is no neck stiffness with structural damage, maybe hypoxic ischemia, encephalopathy, encephalitis, or hypoxia. Other kind include toxic, metabolic, uremic, hepatic, and any drugs used. Coming to treatment, treatment is to reassure him if the patient is very combative, can restrain him physically, followed by NAM formula if the patient has temperature, cold swelling and all in pharmacological treatment. If the patient is too combative or he is restless and all, narcotics and sedations can also be given. Coming to management in specific, in simple, always establish airway braking circulation. If the patient is in shock, fluid therapy. If he is having any electrolyte disturbances, correct electrolyte disturbances. If he is having hypo or hyperthermia, correct accordingly. If he is having hypo or hyperglycemia, treat accordingly. If the patient, we don't have any idea, Pharma cocktail is the one in which it states that provide oxygen support, and the other most common cause of coma is hypoglycemia, so give dextrose infusion, and the other one is usually alcoholics presenting, so replace thiamine, and if there are any suspicion of poisoning, giving an naloxone, and correct if any physiological abnormalities like electrolyte imbalances, metabolic acidosis present. Treat underlying cause like infections. If the patient is a non-seizure disorder, if he's having cerebral edema, anti-edema measures, nutritional supplementation, and in patients of chronic drug abuse and alcoholics. If the patient is in a known case of renal failure, then dialysis may help him. And if there are any other associated symptoms, etc. If required, can infuse specific antidotes. Control, if the patient is progressing into hypertension and encephalopathy, control reduction of blood pressure with labetalol or nitroprusside. If the patient is having edema, then can consider giving him glucocorticoids to reduce the spasmogenic edema and supportive care. Coming to stroke care, rapid assessment and diagnosis has to be done, and usually we should look for the onset of symptoms. When did they begin? And usually this is the 7 days of care in a stroke patient. Detection of symptoms and signs. We call for help, taken to ICU, to hospital, and from emergency triaging, getting appropriate tests done, and decision making whether to thrombolyze him or not. All this should this thrombolysis, if administered within 3 hours, it has a good result. If it is beyond 3 hours, there is increased risk of cerebral bleeding. If the patient presents with seizures, we have many drugs which can be used to control his acute seizures. We commonly use lorazepam, midazolam, and all. If the patient is very complaints of delirium or hallucination and all, we can even consider of haloperidol, pitapin, and all in psychiatric cases. How to approach a patient of meningitis? Starting with empirical antibiotics like cefepime, vancomycin. If the patient is having any suspicion of viral infection, starting with acyclovir. Steroids can be usually given in immunocompetent patients, but should be given in caution with immunocompromised patients. Usually steroids decrease the bacterial lysis. As bacterial lysis increases CNS inflammation, steroids reduce its effect when given concurrently, but studies are done only with dexamethasone. There is a prevalent myth that cerebrospinal fluid counts and other markers are reliable indicator of bacterial versus viral meningitis, which was stated in this emergency medicine article as a misconception. Other factors, if the patient presents with the nutritional deficiencies, correct them. If he is in liver or hepatic failure, according conditions can be done. If he is in non-convulsive status, neurological confirmation, followed by treatment with benzodiazepines, which are the first line therapy for them. Usually non-convulsive status damages neuron, but not as extent to as that of convulsive, as stated in animal studies and case series. So coming to a quick approach of an altered sensorium. If he is having hypoglycemia, give dextrose. If he is in hypoxic, oxygen supplementation. If he is suspicion of toxic, antidotes. If he is in seizure, anticonvulsants. If he is in dyselectrolytemia, correct electrolyte imbalances. If there are any temperature disturbances, corrected. If he is uremic dialect, if he is hepatic, enhance ammonia elimination. This is a slide in which we can categorize the patients with altered sensorium. If he's having shock with altered sensorium, if he's having fever with altered sensorium, to think of meningitis or septic encephalopathy. If he's having trauma with altered sensorium, consider from concussion to diffuse axonal injury. If he's having with bradycardia with altered sensorium, look for any rhythm disturbances or any endocrine abnormalities. Temperature variation with altered sensorium, he can present with hypothermia or hyperthermia. Coming to toxidromes, toxidrome approach in specific. If he's having altered sensorium with electrolyte abnormalities, electrolyte imbalances, always check if the altered sensorium is sudden or progressive. Yeah, the patient can have focal neurological involvement with altered sensation, then suspect abscess, brain abscess. If the patient has is on medication, he can be present with the neuroleptic malignant syndrome or serotonin syndrome because of overusage. This is a slide which states that if the patient has an altered sensorium, initial evaluation, if he is unstable, admit in ICU, secure ABC, stabilize him. If he is combative, then restrain him. If not, consider examination. First, physical examination, and look for airway breathing circulation, send routine blood investigations. If there is improvement with after giving IV infusion, consider it as hypoglycemic. Like, if there is no reevaluate, send ABG, look for shock, respiratory failure. If present, admit to ICU. If it is not present, history and physical examination and toxicological screening may help us. If the patient is improving after glucose and is not improved after glucose, then check for his pupils. If any suspicion of toxic, send blood and urine analysis. Consider opioid poisoning if he has pinpoint pupils. If the patient is not improving with naloxone, then consider alcoholic. Like, if we give thiamine, if you improves, it is Wernicke's encephalopathy. We consider continuing thiamine. If the patient is in shock, respiratory failure, history, examination, screening, any suggestion of trauma, emergency imaging, and treat accordingly. If nothing, then look for stroke, look for any focal neurological deficits. If stroke is present, thrombolysis or medical management. If no stroke, if stroke is ruled out, look for meningitis symptoms and signs. Get an lumbar puncture and cultures done. If no meningitis, neck stiffness and all, look for any other organ dysfunctions. If it is metabolic, because of electrolyte abnormalities, treat them. If it is because of a known epilepsy, get an EEG done and an imaging based on that, treat his seizure disorder. If he is a psychiatric patient, consider giving psychiatric referral. And that's it. To summarize, delirium is an acute condition which need to be evaluated and treated. Prognosis depends primarily on the underlying conditions. If the patient is having no pupillary reflex or his GCS is less than 5, even on third day of assessment in ICU, this is usually associated with poorer prognosis. Categorize altered behavior with symptoms, signs, and work up with necessary investigation to rule out the etiology. This is a multi-component management of delirium symptoms. Make them reoriented, normalize their sleep cycles, prevent their complications, maintain adequate hydration, give family care, good communication, further vision, visual aids can be of use. Encourage activity in them, educate other family members, provide them relaxation technique, and if the patient is aggressive, consider antipsychotic medication. Thank you.
Thank you, Akshit. Very good presentation. and elaborating all the causes of delirium and altered mental status in ICU, and with the flow charts and how to approach and how to diagnose and how to treat these patients as per the syndromic approach. Thank you for that, and I request audience for your suggestions or queries. Hello? Hello? Nobody is responding. Hello? Sir, Akshit,
Sir.
వినిపిస్తుందా?
వినిపిస్తుంది సార్.
Sir, Mohan sir.
Hello, sir.
Nobody is responding.
Excellent presentation, sir.
అందరూ ఆన్ లో పెట్టి ఏమన్నా ఎవరి పనులు వాళ్ళు చూసుకుంటున్నారా ఏంటి రౌండ్స్కి వెళ్ళి?
అదే
Doubt
లేదు
వస్తుంది నాకు.
లేదు డేవిడ్, డిస్టర్బెన్స్ ఎందుకని నువ్వు మాట్లాడుతున్నావు కానీ మాట్లాడలేదు అంతే.
అయిపోయింది. హలో హలో ప్లీజ్ రెస్పాండ్ అంటున్నా కదా, అయినా కూడా ఎవరు మాట్లాడలేదు. నాకు doubt
అలాగే,
ఉంది.
మ్యూట్ నుంచి మ్యూట్ చేయాలి కదా సార్.
నువ్వే మళ్ళీ
ఆ?
క్వశ్చన్స్
Mute చేయాలి కదా.
అడుగుతాయి.
ఒకళ్ళు మాడితే డిస్టర్బెన్స్ ఎందుకని మాట్లాడలేదు.
అది కాదు సార్, అయిపోయినాక ప్లీజ్ రెస్పాండ్ ఎనీ క్వరీస్ అంటే ఎవరు, అప్పుడు డౌట్ వచ్చింది నాకు.
అవుతారు కదా అని చూస్తున్నాను.
అట్టగా సార్, స్టూడెంట్స్ అడుగుతారు అనుకున్నాము, మీరు కన్సల్టెంట్ అడుగుతారు అనుకోలేదు క్వశ్చన్స్.
అలా కాదు, ఇప్పుడు ఐ టోల్డ్ ఎనీబడి కెన్ రెస్పాండ్ ఆర్ ఎనీ సజెషన్స్ ఆర్ క్వరీస్ అన్నాను. ఐ డెంట్ సే స్టూడెంట్స్ ఆర్ కన్సల్టెంట్స్.
అర్థమైంది డేవిడ్.
అన్న అర్థమైంది, చెప్పు, అడగండి మీ ఫీడ్బ్యాక్.
అందుకని అడగండి ప్లీజ్.
క్వశ్చన్ ఏంటంటే, ఎప్పుడు కూడా కన్ఫ్యూజన్ ఒక 5 పాయింట్స్ చెప్పవా
సార్? హలో.
నార్మల్ గా ఎవ్రీ టైమ్ మోస్ట్ ఆఫ్ ద ఫిజిషియన్స్, ఎవ్రీబడి వెన్ ఎవర్ వీఆర్ డిస్కసింగ్
ఎస్ సార్.
ఇన్ ద ఐసీయూ క్యామ్ ఐసీ స్కోర్ మనం ఇంతవరకు కూడా మనం అన్ని ఐసీయూలో చేయట్లేదు.
అవును సార్.
వీఆర్ వెరీ మచ్ ఇంట్రెస్టెడ్ ఇన్ because of there's a 10% increase in the outcomes and mortality. హలో,
చెప్పండి సార్.
సో అందుకోసమని సింపుల్ గా క్యామ్ ఐసీ స్కోర్ మన ఇంతమంది ఆ యొక్క కనెక్షన్ లో ఉన్నారు కదా, ఎంతమంది దే ఆర్ యాక్చువల్లీ ఫాలోయింగ్ క్యామ్ ఐసీ స్కోర్?
అంత టిపికల్ గా క్యామ్ఐసి స్కోర్ ఫాలో అవట్లేదు సార్.
సో ర్యాష్
అగ్రీ ఆర్ నాట్, ఐ డోంట్ నో. How many hospitals are following CAM-ICU?
వాడట్లేదు సార్. అది ఓన్లీ వెన్ వీ హ్యావ్ డిస్కషన్ వస్తే వాడడం తప్ప రెగ్యులర్లీ వీఆర్ నాట్ యూజింగ్. వన్.
So we are
సెకండ్ థింగ్, డాక్టర్ అక్షిత్ గారు, can you tell us how do you the practical approach, because a patient comes here into the ICU with altered sensorium. Suppose he might be, usually we get up alcoholic patient, so lekapothe patient with history of some use of medications. కొంతమంది డిమెన్షియా అంటారు, కొంతమంది పార్కిన్సన్స్ అంటారు, ఇది అంటారు, అది అంటారు. సో పేషెంట్ సార్
అతను చెప్పినట్టుగా నాన్ కన్వల్సివ్ స్టేటస్ ఎపిలెప్టికస్ కూడా మనం అర్థం చేసుకోలేము.
అదే సార్, నాన్ కన్వల్సివ్ కూడా ఉంటది కదా, మనం ఈజీ చేస్తుంటాం కదా అందరికి. పేషెంట్ ఈజ్, ఇఫ్ యూ ఆర్ నాట్ ఏబుల్ టు ఐడెంటిఫై ద కాజ్ అండ్ పేషెంట్ ఈజ్ అన్కాన్షియస్, వీ డూ అన్ ఈజీ టు ఐడెంటిఫై నాన్ కన్వల్సివ్ సీజర్స్ ఉన్నాయా లేదా అని. సో అది ఒక అప్రోచ్ చెప్తారా? హౌ విల్ యూ రూల్ అవుట్ ఇన్ ప్రాక్టికల్ గా? బికాస్ కొంతమంది ఏం చేస్తారంటే, న్యూరాలజిస్టులు, దే గివ్ ఎ కన్సల్టేషన్ టు దెమ్, దే గివ్ ఎ సైకియాట్రిస్ట్ విల్ యాడ్ లోరాజిపమ్ డ్రగ్స్, పేషెంట్ కంప్లీట్ గా నాక్ ఆఫ్ అయిపోతాడు. యా ప్లీజ్.
If the patient is if a patient is in altered mental status and if initially evaluate for his hemodynamic stability, if he is unstable, airway breathing circulation needs to be taken care. If he is stable and is very aggressive, then restrain him. If he is cooperative, look for his airway, if he is able to protect it, how is his breathing pattern, send routine
ఇది హిమోడైనమికల్ స్టేబుల్ ఉన్నాడండి పేషెంట్, పేషెంట్ ఈజ్ హీమోడైనమికల్ స్టేబుల్, కొంచెం ఏంటంటే కన్ఫ్యూజన్ ఉన్నాడు.
ఓకే సార్.
సో అజిటేట్ అవుతున్నాడు వాడు. రెసిస్టెన్స్ చేసాము.
ఓకే సార్. సో ఇప్పుడు ఎయిర్వే బ్రీతింగ్ సర్క్యులేషన్ చూసుకుంటాం సార్. నార్మల్ రొటీన్ బ్లడ్ ఇన్వెస్టిగేషన్స్, ఎలక్ట్రోలైట్స్ పంపిస్తాం సార్. ఇఫ్ ద పేషెంట్ who is an altered sensorium has improved with giving glucose, IV glucose, then maybe because of hypoglycemia, ఎలాగో మనం RBS చేస్తాం కాబట్టి తెలిసిపోతే hypoglycemia is very rapidly reversed. If the patient is not reversed even after dextrose, reevaluate, send an ABG. If he is having any shock or because of hypoxia he is unconscious, or because of hypercapnia is unconscious, if needed ventilate chestam sir. If the patient has
Akshit, coming to ABG,
sir.
what are all the causes you see in ABG will cause altered sensorium from the beginning, from the PH to last?
If the patient is in acidosis, if it is respiratory acidosis, because of hypercapnia he may be in unconscious state. If it is because of severe metabolic acidosis associated with high sugars, because of decay he can be in altered state, altered mental status. If it is because of hypoxia, type 1 respiratory failure, he can be in unconscious state.
Next,
presence of any dyselectrolytemia like hyponatremia or hypernatremia, because of which he can be unconscious.
and lactate will be there.
Hypoglycemia, because of hypo or hyperglycemia, because of which he can be unconscious.
Yes, lactate also is displayed.
DK ఎలాగో చూస్తాం కదా సార్.
Lactate, septic shock.
Okay, septic shock, sepsis.
Septic shock. And bilirubin also is displayed. Bilirubin also is there in the ABG.
Yes sir.
Yeah, in cirrhosis. And if patient is hyperkalemia, CKD, so patient will be in altered sensorium. So ABG give a lot of information regarding this identification of altered sensorium. Next, go.
If the patient is having even after IV administration, after assessing GCS, look for pupils and look for any intoxication. If he is having pinpoint pupils, then can suspect opioid poisoning, can give naloxone. If it is not reversed with it, if he is alcoholic or malnourished, can start thiamine. If the patient is having fever, get a history screening done. Yeah, and if there is any history of trauma, get an CT done to look for concussion to diffuse axonal injury. Concussion, contusion may be present, EDH, SDH, SAH, any intraparenchymal bleeds with intraventricular extension, any diffuse axonal injury, any fractures, any C-spine injury, all that can be dealt accordingly. Even if he is not having any history of trauma, look for stroke using AVPU score or Cincinnati stroke scale. If he is having any focal deficits, you can, if it is window period, can thrombolyze. If not, medical management with anticoagulant and antiplatelets. And if the stroke is ruled out, look for neck stiffness and meningismism. If there are any signs of meningism or neck stiffness, can after CT or after looking signs of raised recipe, can perform a lumbar puncture and can start accordingly. If it is bacterial, viral, bacterial meningitis, tubercular meningitis, viral, fungal, rarely parasitic can also be seen. If the patient doesn't improve with this, look for any organ dysfunction. If he is in sepsis, can be septic encephalopathy, metabolic derangements, metabolic encephalopathy, known case of seizure disorder because of any anti-epileptic, anti-convulsant misusage can cause this. If he has a known psychiatric disorder, consider giving psychiatric referral. If the patient has a dyselectrolytemia, as we have sent already, CBC and all, electrolytemia, treat dyselectrolytemia. If he is in having hyperammonemia, which can be known using serum ammonia levels, can consider hepatic failure. If his creatinine renal function tests are raised, can consider uremic encephalopathy. These are all which I can state. If anything is there, please add them, sir.
I will give one case scenario. Akshit, you know that we treated one patient, a 45 years old obese patient presented with a confusion, altered sensorium, and high fever, 104 temperature, tachycardia, and respiratory rate is around 10 to 11.
Okay.
So that ABG shows metabolic acidosis and elevated carbon dioxide, hypercapnia, and respiratory, both mixed acidosis.
Okay, sir.
So I asked the students to how will you approach this patient? What is the cause, and quickly how do you identify and treat this patient? Hello? I request students to respond.
సార్ మీరు ఎవరున్నారు సార్ స్టూడెంట్స్ మనకి ఇంకా ఐడిసిసిఎం వాళ్ళు తృప్తి
IDCM వాళ్ళు కానీ ఆ రఘు వీళ్ళు ఎవరో ఉన్నారు కదా,
ఉన్నారు, సెంజు తృప్తి ఉన్నారు.
ఎవరు రెస్పాండ్ అవరా?
లేకపోతే వాళ్ళ టీచర్ ఉన్నారుగా, రాణి మేడం అండ్ ఎం శ్రీనివాస్.
ముందు స్టూడెంట్స్, ఇఫ్ దే నాట్ రెస్పాండ్, అదర్స్ కెన్ రెస్పాండ్.
సార్ ఒక్కసారి క్వశ్చన్ సార్, సారీ.
మీరు వినలేదా
సార్? మళ్ళీ
అలా కాదమ్మా, ఇప్పుడు యూఆర్ కాన్సన్ట్రేటెడ్ ఆన్ ప్రజెంటేషన్, యూ వాంట్ ఆస్క్ అగైన్. ఓకే, ఎనీవే, 45 years old obese female presented with altered sensorium, fever 104 temperature, tachycardia, and low respiratory rate around 10 to 11. ABG shows metabolic acidosis and hypercapnia, respiratory acidosis. This is the case scenario. And hyperglycemia, 300 around blood sugar.
Fever with metabolic and respiratory acidosis.
Yes.
First differential with altered sensorium. First differential would be to rule out meningitis or meningoencephalitis, sir. And hyperpyrexia, if it is beyond 1 or 2, then central some vascular event or hemorrhage in midbrain or pons, where temperature regulatory centers are present, should be another differential diagnosis, sir. And sepsis anywhere can also cause septic encephalopathy. So we have to look for the other sources of infection.
See, Shravya, I think first you have to rule out is there any focal cause or not. You have to ask the examiner, are there any focal signs or focal neurological deficits? Until unless you find out all those things, you can't differentiate either it is because of a local issue or it is a systemic issue.
No focal deficit.
No, ఆవిడ అడగాలి కదా సార్.
అదే ఆవిడ అడగాలే, చెప్తున్నా, క్లూ ఇస్తున్నాను ఆవిడకి.
If there is no focal deficits, and if the examination
this started with fever patient లేకపోతే altered sensorium with fever అంటే together start అయిందా patient కి?
Sudden onset of altered sensorium, they said.
Sudden onset, but
she was doing cooking, followed by she came into the hall and she become drowsy, followed by
fever in రోజు fever in రోజు
ఆ రోజే అన్నారు. No extra fever before. So So what is okay? Initially we thought it is a sepsis, septic encephalopathy because of fever, tachycardia, acidosis, because of obesity and hypoventilation, hypercapnia. Okay, that's one. Next, fever, high grade fever is there. So septic encephalopathy or viral encephalitis.
ఈసీ అనేది డయాబెటిక్స్ మీద ఉందా ఏమైనా? Because diuretics మీద ఉందా? Hyponatremia. If she is a diabetic, probably
no electrolyte disturbances. Not on any diuretics. She is a hypertensive and diabetes on medication. So we took all the history of this thing. Finally, okay, we ruled out all these causes, common cause of septic encephalopathy or encephalitis or all these electrolyte imbalances. Did MRI to rule out any stroke. So finally, it is turned out to be a poisoning. So she took tricyclic antidepressants. But actually, did you remember that case?
Yes, sir. Obese female, we even intubated her once.
Yes. So what she consumed?
Benzodiazepines only, sir.
Tricyclic antidepressants.
Rendo, sir. Benzodiazepines or tricyclic antidepressant.
Combination she consumed and she became unconscious. She was combative, intubated, and LP. Everything is done. Finally, we got a doubt that husband is not revealing anything. Patient is unconscious. And one thing he told, she is consuming some antipsychotic drugs. Then we took the Riles tube aspirants and sent for toxicology. Toxicology report also came as a tricyclic antidepressants. So after 2-3 days, she became conscious, but she is not accepting that she consumed. But our toxicology report shows
high levels of tricyclic antidepressants with
high levels of TGA. So approach should be very. We had so many reasons will be there. Very rare causes also will cause altered sensorium. Once you rule out common, we have to look for all the possibilities.
David, can I add?
Yeah, please.
That is why in case of any patient comes, just I suggest one approach, that is altered sensorium or coma patients. The duration, it is happened within hours, within days, or within weeks. So according to that also we can evaluate the this coma alteration cases. So it is happened within hours means that way what we have your thought is right.
Hello, Namaste, good morning.
Good morning. Hello.
Hello, David.
Cheppandi madam, cheppandi.
David, yeah, they suspected poisoning, overdose of something, but what I was thinking is like with tricyclics or benzodiazepines, why so high temperature? Usually with recreational drugs, you get high temperature. But with this, do we get
cause malignant hypertension?
104 temperature annaru, but when they have 104 temperature, but the respiratory rate is quite low,
because of
I was wondering maybe benzodiazepines also must have taken. I don't know.
That's
why respiratory rate is low. I was thinking when temperature is so high, why respiratory rate is so low? I was thinking not sitting in fluid.
It was a combination of tricyclic antidepressant with benzodiazepine.
Maybe.
Almost 15 or 20 like that she consumed, but she never accepted, madam. Even discharge time lo adina kuda not accepted, and there is a lot of family disturbances.
Did you say she has arrhythmias? Tricyclics usually arrhythmias vastadi kada.
Tachycardia undi. Tachycardia 140, 150 heart rate.
Okay.
Echo was
Right.
normal,
Right.
and she had a right heart.
But
Okay.
only this fever has confused it. But is she on medication? Like tricyclic antidepressants with unnara? Is she on a regular medication?
No, sir,
Yes.
not regular.
మరి ఉంటే
Not regular. No, no. అంటే irregular గా అప్పుడు depression లో ఉన్నప్పుడు used to take 1 or 2 tablets. When husband issue is
there. See, suppose she might have taken. See, this fever is a different scenario. She might have taken a drugs on that day. Maybe her regular dose, 1 or 2 tablets ఏదైనా వేసుకొని ఉంటుంది. వేసుకున్నప్పుడు బట్ ఆ లెవెల్ లైక్ ఇప్పుడు సపోజ్ 10 టాబ్లెట్స్ తీసుకుంటే రైట్స్ టు ఆస్పిరేట్ ఎంత లెవెల్ ఉంటుంది, 1 టాబ్లెట్ ఎంత తీసుకుంటే ఎంత లెవెల్ ఉంటుంది, ఎట్ వాట్ టైమ్ యూ హ్యావ్ ఆస్పిరేటెడ్ దట్, బికాస్ యూ హ్యావ్ డన్ సిటీ స్కాన్, ఎంఆర్ఐ, సిఎస్ఎఫ్ ఇవన్నీ చేసిన తర్వాత డౌట్ వచ్చింది.
So the first day itself, what we will do in any unconscious patient, once you put the rail tube, we will aspirate and we will keep it there. That is our protocol.
You'll aspirate and
keep that contents.
Okay, so you aspirate around 10 ml and keep it. Okay, oh great. Nice.
అది రెండో రోజు మాకు డౌట్ వస్తే నెక్స్ట్ డే we send that aspirant.
Okay. So
after evaluating all this.
సో ఒక టాబ్లెట్ తీసుకుంటే మీ లెవెల్ ఎంత వచ్చింది ల్యాబ్ ది, అది ఎలా కోయిన్సైడ్
అది
బికాజ్ బ్లడ్ లెవెల్స్ ఓకే వి కెన్
they told it
బ్లడ్
very
లెవెల్స్
high.
రెండో డౌట్ వస్తే ఏం పంపుతారు? రెండో డౌట్ వస్తే ఏం పంపుతారు?
అదే what we aspirated the contents.
Okay,
contents
right.
we stored for all
ఎక్కడికి పంపుతారు?
the unconscious patients. We send for lab.
ఎక్కడికి పంపుతారు సార్?
Toxicology. ఏంటి సార్?
ఎక్కడికి పంపుతారు టాక్సికాలజీ?
మా ల్యాబ్ పంపిస్తే ల్యాబ్ వాళ్ళు హైదరాబాద్
పంపిస్తారు సార్, హైదరాబాద్
యాంపత్ వాళ్ళు హైదరాబాద్ పంపారు. 3 days లోనే ఇప్పుడు వచ్చింది రిపోర్ట్ విత్ హై డోసెస్ ఆఫ్ ట్రైసైక్లిక్ యాంటీడిప్రెసెంట్స్ అండ్ బెంజోడైజపైన్ పాయిజన్.
ఒక్కసారి చూడండి ఆర్ వి మిస్సింగ్ ఎనీథింగ్ అని, ఎందుకంటే there might be most of the patients if you send even hanging una ఏదున్నా కానీ benzodiazepines most of the times it will be positive ఉంటుంది barbiturates, urine toxicology పంపిస్తే sometimes it is falsely positive. అది ఒకసారి చూసుకోండి because so once you know the toxicology you have stopped all antibiotics. How the fever
మనకు వచ్చిందే అది 4 days తర్వాత, ఆల్రెడీ 3 days అయిపోయింది, 1 week. By the time we stopped all the antibiotics and patient shifted to room on 7th day, patient was discharged.
So ultrasound is normal because UTI atlantithi em
MRI normal, ultrasound normal, CSF analysis is normal, and procalcitonin is normal.
David, already 3-4 days అయితే ఇంకా అంత హై టెంపరేచర్ ఉంటదా?
తగ్గిపోయింది మేడం. 2 days ఫస్ట్ డేనే టెంపరేచర్, తర్వాత తగ్గిపోయింది. నెక్స్ట్ డే నుంచి 99, 100 ఆ రేంజ్.
బట్ డ్రౌజీనెస్ అన్కాన్షియస్ స్టేట్ ఎన్ని డేస్ హిస్టరీ ఉంది?
ఆ డే ఆఫ్ అంటే మార్నింగ్ ఎప్పుడు 12 o'clock she become drowsy followed by unconscious by evening.
మరి మీ దగ్గరికి వచ్చేసరికి 3-4 డేస్ అన్నారు కదా?
కాదు ఆ రోజు ఈవినింగ్ వచ్చింది, 3-4 days కాదు.
ఓకే,
3-4 days రిపోర్ట్ స్టార్ట్ అయింది మేడం.
రిపోర్ట్స్ వచ్చి 3-4 days తర్వాత.
అయితే గ్యాస్ట్రిక్ కంటెంట్స్ కాక యూరిన్ కూడా పంపించి ఉంటారు కదా టాక్సికాలజీకి?
we send all blood, urine and gastric contents.
సో యూరిన్ లో కూడా మెటబోలైట్స్ ఆఫ్ ట్రైసైక్లిక్స్ వచ్చిందా?
ఉంది యూరిన్ రిపోర్ట్ కూడా వచ్చింది.
యూరిన్ లో కూడా ట్రైసైక్లిక్స్, బెంజోడైజపిన్స్ అని ఇచ్చారు మేడం.
ఓకే రైట్, ఓకే, థ్యాంక్ యూ, బై.
So thank you all for active participation, and thank you Akshit for very good presentation.
Thank you, sir.
You send all these PPT to our group.
Yes, sir.
Satish, yeah, tell me.
Okay, small. There is a possibility of the testing లో false positives, cross reactions ఉండొచ్చు.
Yeah.
అదొకటి చేయండి.
we discussed with the pathologist in Hyderabad about this any false positive or anything, but he clearly told there is a very high doses of this thing. She must be consumed minimum 10 tablets of each.
Then it's convinced. Thank you.
Right.
Good presentation.
Thank you.
Thank you all. Thank you, Akshit, once again for a good presentation.